Our next speaker is actually our newest faculty member, Dr. Beth Carlton. Welcome.
Thank you. So I'm going to shift gears a little bit and talk today about schistosomiasis and whether or not it can be eliminated in China. I think a lot about this issue because I have worked on studied the re-emergence of schistosomiasis in southwest China. And I think it's an ongoing question of whether what we're going to be dealing with over the next 10 or 20 years is just repeated emergence of this parasite, or if we can make the next step and move towards disease elimination. And I will say this is not a total change of gears from the last talk, in that in China, schistosomiasis really is a occupational health problem, in that it affects rural farmers, largely the rural poor. Oops. So just briefly, schistosomiasis is a waterborne infection that infects about 200 million people worldwide. As you can see on this map, about 90% of the cases are in Africa, although there are cases in Brazil, in the Caribbean, in the Middle East, and in Asia. In Asia, it's found primarily in China and the Philippines, with a limited amount of cases in Indonesia. And people become infected with schistosomiasis when their skin comes in contact with water contaminated with the parasite. The infectious stage are called cercaria. Cercaria bore in through your skin, migrate through the lungs into the liver. They reproduce. They very romantically mate for life, and begin laying eggs. And the eggs are really what causes damage. Pathologically, the eggs are also what is excreted from the human host and can lead to future infections. So in the case of Schistosoma japonicum, the species found in Asia, eggs are excreted in stool. In the case of Schistosoma hematobium, which is exclusively found in Africa, eggs are excreted in urine. The other important part of the schistosomiasis life cycle is the need for a snail host. So if you look back at this map, you can see this kind of patchy distribution of the parasite even within countries, and some of that has to do with the need for the ecological conditions that can support the snail. And so the parasite must pass through a snail before it becomes infectious and infects other people. So what are the health effects of schistosomiasis? Well, it can cause fibrosis of the target organs, the liver and the bladder. It can cause anemia. It can cause impaired growth and development. Schistosoma hematobium is a class 1 carcinogen. The jury is still out for Schistosoma japonicum. But most importantly, I think schistosomiasis belongs to a class of parasites that not only affect people who are poor, but may sustain poverty by impairing child cognitive development, by impairing worker productivity. So it's one of these kind of poverty-trapped diseases. In China, schistosomiasis has largely been a major success story. In the 1950s, there were about 12 million people infected in 12 provinces, and at that point, the leadership recognized that this was a major public health problem, and it was really impairing worker productivity in the countryside, and the National Schistosomiasis Campaign was launched. This campaign, in some ways, has been ongoing for 60 years, which is pretty incredible, particularly as we'll talk at the end about kind of the state of schistosomiasis control elsewhere in the world. Today, there are less than 1 million people infected in 7 provinces, and the country is now aiming for schistosomiasis elimination. So let's just talk briefly about why elimination may or may not work. What the elimination campaign has in its favor is the availability of a very cheap, very effective, and very safe drug called praziquantel. Praziquantel has been administered at the population level to millions of people. It's administered, if infection prevalence is high enough, at the population level without screening for infection. In China, there is enormous political will to eliminate this disease, which most of the time works in its favor. Occasionally, it works against it in that at times there's incentive not to report disease that is present. There's past precedent in that Japan was able to eliminate schistosomiasis. There's this amazing public health infrastructure that I just mentioned. And in the wake of SARS, China updated its national infectious disease reporting system, making it as close to real time as possible. All township hospitals have networked computers that can report cases that can be seen almost instantly by provincial and national CDC. So what's going against elimination? Well, first of all, there's no vaccine, and that is a pretty major problem. And not only is there no vaccine, but there's very limited immunity, so that if a person is treated today, they can become infected tomorrow. Schistosomiasis is in China. Schistosoma japonicum is a zoonotic infection. We think bovines play a large role in sustaining transmission, but there are at least 40 known competent mammalian reservoirs for this parasite. Furthermore, there are fairly weak diagnostics for schistosomiasis when infection prevalence declines. As is the case for many helminthic infections, the diagnostic tools we have are tools that were developed 40, 50, 60 years ago. They work fine when infection prevalence is high, but as the number of worms in an individual declines, the ability to detect infections declines. And this is really important if you think about as you approach elimination, you don't want to just be able to detect the people who are heavily infected. You want to be able to root out the residual pockets of infection. So this study was published right as I began my work and had a large influence on where I went. It showed that in Sichuan province, China, and you can see on the map, Sichuan province is located in southwest China, just east of the Tibetan Plateau. Schistosomiasis had reemerged excuse me, in several counties where it had previously been declared controlled. And this study was published by my collaborators at the Sichuan Institute of Parasitic Diseases and Song Liang. And so as a follow-up to that study, we went out to 53 villages in 3 counties where we know reemergence had occurred, and we just wanted to see on the ground what was going on. And what we found were that human infections were present in 18 of 25 villages with prior evidence of reemergence. What was most surprising is we also looked at 28 villages with no prior evidence of reemergence and found infections in 17 of those villages. Further, what we found is that, this really kind of underscored the fact that the surveillance system that we had was not working. The surveillance system at the time really relied heavily on the detection of acute schistosomiasis cases. This is when a person becomes infected, a small fraction of the population who becomes infected has an acute reaction to the parasite. This forces them it's severe enough that people present to a healthcare facility, and this is a reportable disease. An additional surveillance tool is looking for infected snails. We looked for infected snails in all 53 villages with trained research workers, did a very extensive survey, collected thousands of snails, and found exactly 1 infected snails. So both of these methods are just missing, are grossly underpowered to identify all places where transmission is happening. So I think at this point, it's really, there's a need to rethink how do we do surveillance for schistosomiasis. And surveillance, you could think about this not just in schistosomiasis, but for all sorts of parasitic infections that are the types of infections that don't make people acutely ill, but are these chronic diseases, chronic infections that affect people who have low access to healthcare facilities. One method is identifying high-risk individuals who can serve as sentinels for surveillance or can serve as targets for interventions. Another method is identifying high-risk environments, which similarly can serve as sentinels for surveillance or targets for intervention. And finally, there's a need to develop diagnostic tools. So for this last chunk of the talk, I'm going to talk really about how and whether there exist high-risk individuals that we can identify. And if there's time, I'll mention some of the progress on diagnostic tools. So we know for any helminthic infection, or almost all helminthic infections, the number of worms in the population is aggregated. It's not distributed normally in the population. So most people will have no or very few worms, and a few people will have a lot of worms. They're called wormy people in the literature, and they are responsible. The thought is that 20% of the population is responsible for 80% of the downstream infections. So this is a population that needs to get treated. These are all based on cross-sectional studies. What we wanted to know is, are the same people repeatedly infected over time? So are there parasite reservoirs? Can we identify this population and target them so that they no longer serve as reservoirs of infection? So we had assembled 2 cohorts. This is based on data that had been collected as part of the Berkeley-Sichuan research study. And I'll walk you through the first cohort. The first cohort had a baseline infection survey. We asked everybody, we administered a very complex exposure survey, and then we followed them up at 2 time points. Baseline was 2000, follow-up was 2002, and follow-up 2 was in 2006. And at each time point, if someone tested positive for infection, we treated them. We did this again in the 53 villages that I mentioned previously in the Re-Emerging counties. So we have 2 cohorts, and we calculated a ratio to evaluate whether the same people were being repeatedly infected over time. And this ratio is the observed proportion of people with infections at both follow-up periods divided by the expected proportion of people with infections at both follow-up periods. So ostensibly, if this ratio is greater than 1, we're seeing that infections are clustering in a few individuals. If this ratio is less than 1, we'd actually see that infections are disaggregated, that infection at time 1 may protect against infection at time 2. So how do we calculate the expected proportion of people with infections at time 1 and time 2? You can do this quite simply by looking at just the probability of being infected at time 1 based on prevalence times the probability of being infected at time 2 based on prevalence. That is our simple prevalence-based estimate. But you could argue that the people who are repeatedly infected may be also most heavily exposed. So can we develop a metric that accounts for exposure as well? So in other words, what is your probability of being infected at time 1 given your exposure that you report? And I'll just say briefly that our exposure measures were actually rather complex. There's a number of variables. They're potentially nonlinear relationships or correlation. And so we used a machine learning algorithm to fit the exposure model to the infection data, and therefore it predicted for each individual their probability of infection at time 1 and time 2 given their exposure history. And what we found, if you look at the ratio, is that, in fact, infections do appear to cluster in a few individuals. If you look at cohort 1 for the simple prediction metric, this is just based on prevalence, we found 1.5. We found that the number of people with repeated infections were 1.5 times greater than what we would expect by chance alone. When we account for exposure, it reduces to 1.3. In cohort 2, the ratio was much higher, 5.8 and 2.06. And if you look at the probability, this is highly likely due to chance. Highly unlikely due to chance. So I think what this says is that, in fact, there are these individuals who are repeatedly infected over time that might serve as appropriate surveillance targets. There's several possible explanations. One is that we did a crummy job of dealing with exposure, and our model just needs, we should have measured exposure better. Another explanation is that people who are infected not only have high exposure, but high susceptibility. This is actually a good thing when you think about elimination, because if susceptibility varies across the population, as does exposure, then as exposure declines, the at-risk population also declines. The third explanation is that people who appear repeatedly infected do not, in fact, have new infections, but have residual uncured infections. This is obviously not good news if it's true for elimination, because it suggests there's treatment failure going on, either because the drug isn't working or people have stopped taking their medicine. And I'll just end by saying we have a new study that's just about to come out showing that, looking at the DNA of the Miracidia collected from people over time, and showing that at least in 2 individuals, they do have parasite siblings at different time points, suggesting that they have the same adult host within them at multiple time points, suggesting there was some sort of treatment failure. Whether that's due to drug failure or noncompliance, we don't yet know. So I will I'll stop here and just say thank you to my collaborators in Sichuan Institute of Parasitic Diseases, who are really an amazing research team, and my collaborators at Berkeley, Emory, and University of Florida. And this was largely funded by the National Institute of Health. So thank you. Okay. Are there any questions?
So you presented sort of three pieces, individual, environment, and treatment. And I was expecting, given your appointment, you start talking about the environment. Are there any potential environmental interventions that make a difference?
Absolutely, yeah. So there are a number of environmental interventions, and it depends how widely you think about environment as well. You can define, if you think about kind of from a GIS perspective, you can define high-risk environments just in terms of vegetation and where snail habitat might be. If you zoom in closer, one of the things we're starting to find is that human waste is commonly used as an agricultural fertilizer in these areas, and that seems to be a big risk factor for reinfection and kind of sustaining infections. So I mean, the way I think about it is especially when you think about emergence and control, that you need parasite import, but you need something in a village to keep that cycle going or get that cycle started when if a parasite is introduced. And night soil, the use of human waste as an agricultural fertilizer seems to play a role. Jury's still out about whether bovines play a role, just the number of bovines that are in a village, because they are large and produce a lot of stool. So they can be large sources of parasites as well. So certainly an area of interest.
In the same way that there are more wormy people, can there be more wormy snails?
The snails are the giant amplifier in this life cycle. So an infected snail can produce thousands, or I think it's hundreds of parasites per day. The snail has a very inefficient path in the life cycle, in that it has to find a human host, and the parasite doesn't really know where it's going. But we kind of think of all snails as created equal, and maybe that's naive, but they magnify things at such a great level that if they're slightly more or less effective at propagating new cercaria, it probably doesn't have as large an influence. So, thank you. Oh, Lily? There's lots of ideas. One of the things, obviously, at looking at village-level properties is you need a much larger sample size. So there's been challenges in terms of doing good study design. One of the things that I'm really interested in, which is kind of somewhere between environment and social behavioral health, is urbanization is creating enormous demographic change in these communities. So you go out to rural villages and you see grandmas and grandpas and babies, and the whole middle population is missing. Many folks do return at planting season to help with planting and return again at harvest. And there's some thought that these rural to urban migrants may be reservoirs for infection because they're getting infected while they're in the village, they're going away, missing treatment campaigns, coming back and providing infections again. But we don't have evidence of that. It's all ideas at this point. So, one more question? Well, so the biggest snail predator at the moment is a molluscicide that they apply with a vengeance in all these villages. So it's an interesting question, and one of the biostatisticians I worked with, who's married to an ecologist, always asks, what are we doing to the snail population? Are we just breeding more resistant snails? And as far as I know, there hasn't been a lot of work on that in China, that the emphasis is just kill the snails. And I think it's a very relevant question. And there is some efforts elsewhere in the world to really put in predators, to introduce predators of snails into the ecosystem for control measures. So, yeah. So, thank you very much.